I'm Tom Carroll. I'm the director of the voice program at Brigham and Women's Hospital in Boston. And today I'm going to talk about glottic insufficiency, reflux, as they present similarly in patients with something similar to throat clearing or mucus in the throat, or sometimes even a lump sensation. And oftentimes the knee-jerk reaction when people come in with those vague, I call vague throat symptoms, is that they are given the reflux diagnosis presumably right away. And while it is reflux in some of those patients, there's definitely some more exploration that has to happen. Oftentimes the laryngeal exam will help us. The history is of utmost importance, and sometimes it just ends up being trial and error to get the patient better. Typically, if a patient presents with throat clearing and or cough or mucus sensation, and they fall into the more experienced years of wisdom, older patient category, I often ask them if they have these symptoms while talking, laughing, and those help me, differentiate which way I'm going to go with the patient. It would be weird for somebody in their 60s or 70s to come in all of a sudden with new onset reflux disease, although it can happen. So I think outside the box with these patients and try to determine if I really need to put them on a new medication. So the typical course for a patient who comes in with vague throat symptoms is the history, of course, doing a laryngoscopy and seeing if there is evidence on strobe of subtle air loss. They're not getting full closure of their vocal folds, or if they do get full closure, it's a short touching presence in the glottic cycle. So that's what we call short phase closure. Almost like their vocal folds are clapping rather than spending full time 50-50 touching versus not touching during the glottic cycle. And if there's evidence that they're squeezing with other muscles to make a voice. Then it comes down to patient preference sometimes, because you can talk to a patient about procedures to fix this problem, and some people are definitely not keen on that right away. They want to do everything conservative possible first, which I always am for. I'll have my speech pathologist work with them and see if they are stimulable for voice improvement, for improvement in their throat clearing, their mucus sensation, just with behavioral change. And if we're suspicious that they may have a reflux component or an allergy component or something else, we'll definitely start the treatment process there as well. I'm moving a lot more also to doing upfront testing for reflux disease in these patients rather than empirically putting them on medications that stop acid for a few different reasons. One is it's a very expensive problem in this country. Proton pump inhibitors are one of the leading financial sinks for our system in healthcare. The patients don't want to be on it because they've been on Google and they've read everything bad about proton pump inhibitors that exist. And in reality, those studies aren't perfect, but they are out there, and we need to acknowledge them and talk to our patients about them and talk about alternatives. So I typically recommend pH impedance testing with a full column impedance catheter that I don't do myself, but I have worked closely with my GI colleagues. The end result is we find out if the patients have acid reflux, non-acid reflux. What are our targets for therapy? Maybe they have no reflux at all. And in patients who have no reflux at all, then I usually move to something related to their glottic insufficiency. And remember, these are the vague, subtle throat complaints. This is not all comers who we think may have reflux disease. There's definitely more slam dunks historically that you'll say, let's just move to treating you for reflux because your story's really good. You've got heartburn, you're tasting acid in your mouth, you've got typical GERD symptoms, and it's not just these subtle findings and subtle complaints. Globus sensation, or a lump in the throat, is another one people often chalk up to reflux disease, but it can be an etiology of other things. The same patient group who has subtle glottic insufficiency, who are using other muscles to squeeze, I find often relieve that symptom after we correct their glottic insufficiency. And I think the reason is they feel the same muscles that are helping compensate for their voice problem when they swallow. So these muscles almost are overworked and tired, and they're the strap muscles that elevate and depress our larynx as we swallow saliva or what have you. So it's not necessarily a reflux problem, it's the fact that their bodies and their brains are figuring out how to compensate for a voice issue, and they're feeling it during a swallow, but they also have symptoms of vocal fatigue, effort. But I'm sure those listening can appreciate how vague and how trial and error must play in this patient group. I think stroboscopy now plays a huge role in the management of these patients with vague throat symptoms, and for the same reasons I mentioned earlier, which are subtle air loss or subtle glottic insufficiency can give people hyperfunctional changes that lead to the same symptoms of lump sensation. They clear their throat because I think their brain doesn't hear the voice they're ready to hear, and they think there's mucus in the way and they need to get it out, so then they sort of restart their and let me start again, and then they do. But really it's just that their vocal folds don't entrain vibration right away. So you can identify patients with early atrophy or atrophy in general of a mildly weak vocal fold that may be playing a role. And it's not my first move. I don't want people to perceive that we just rush in and inject vocal folds, in a diagnostic fashion. We do that, but it's usually after the patient's had a chance to work through the behavioral modifications, potentially with a speech pathologist, either through voice or through habitual throat clearing or desensitization for cough and other pathologies. And many of these patients have also tried or rejected the idea of reflux management, or are just typical Americans and don't want to do anything but take a pill. And then the pill doesn't work because not all reflux problems are acid problems. Another change in my practice recently has been using more alginates. So we use medications that actually form sort of a jelly-like flotilla in the stomach that prevent the bolus of stomach contents from going backwards. And it's really the only barrier agent short of a surgery to fix potential reflux issues. So I often, and my patients want more information before they start something they're going to have to take 3 or 4 times a day. But if you do reflux testing and there's any evidence that they're refluxing as high as their pharynx or numerous times into just below their upper esophageal sphincter muscle, they will accept the alginate trial because it's not surgery. It's basically made from seaweed and calcium salts, and they don't feel like they're doing something that's medication or unnatural. It's an over-the-counter product. Unfortunately, the American version is not ideal for that. It's got aluminum in it, and doesn't have as much of the alginate, so ordering the medication has to be done from overseas. But anecdotally, patients are liking it, and there's actually a couple good papers out there that have shown the benefits of alginates. So in summary, it's finding the right diagnosis through trial and error, through empiric trials, through objective testing, through patient preference, through working with our other colleagues in GI and speech pathology, ruling out pulmonary disease, allergic disease, sinonasal disease, and coming back to the fact that you actually need a good examination of the larynx and an open mind and the ability to augment people's vocal folds sometimes in a trial or diagnostic fashion to see if that solves their problem. I recently looked at some patients. We did fundoplication surgery for presumed reflux, and they had objective testing. It showed events high in their esophagus or into their throat, and we were right about 8 out of 10 times. Then their primary symptom went away most of the time, or some of their LPR symptoms went away the rest of the time. But for the 2 that didn't, their reflux symptom index dropped to normal when we augmented their vocal fold. So it wasn't that they had reflux causing their reflux symptom index to be high. It was more like a vague throat symptom index that eventually normalized when we improved their glottic insufficiency, which was diagnosed using good laryngovideo stroboscopy and an open mind. I think when I look at reflux disease now, I presume every patient's got non-acid reflux, which every patient does. And then there's a lot of people who have an acid component to their reflux, and that's what proton pump inhibitors and H2 blockers work on. But there's good evidence in the literature that the number of reflux events doesn't change whether you stop acid or not. And that came about when we had good full column impedance catheters and data to show that the liquid still goes up. If you look at just nasopharyngeal pH, for example, you'll see wide changes in people who have a lot of acid environment in their throat. But then there's other studies that they've done with both a nasopharyngeal probe and a full column impedance probe, or at least an impedance probe, that showed that those events weren't coming from the stomach. It was just change in the pH of the mouth and the pharynx. There's value to knowing that, but I think you need full column impedance. It's the only thing right now that we have that really looks at the path of the liquid as it comes up, how many times, how far does it go. It's not perfect. There's some difficulty in examining the events that actually cross the upper sphincter, because what do we do when we reflux? We swallow, we burp, we do something, and then reading that as a liquid event can be tricky. So I think the most interesting aspect of these full column impedance catheters are going to be the events that get up right to the upper sphincter but don't go past it, and we have to look at that number of events. So when you presume that somebody has reflux, think about pepsin with an acid cofactor. Treat the acid in people who have acid reflux. With impedance, you'll know, because it has a second pH probe, if the stuff getting up to their throat is still acidic or not. If it's not acidic, maybe treating their LPR symptom with acid blockers isn't going to make all the difference. And if we can potentially save money by looking up front with testing, it might take some of that PPI burden from the financial sink that we are in now from an LPR perspective. So getting the right diagnosis is important.